Welcome to Breaking the Fungal Recurrence Cycle, the Importance of Disinfecting Footwear. My name is Dr. Bryan C. Markinson, and I'm from the Icahn School of Medicine at Mount Sinai in New York City. My disclosures for this presentation are that this is a non-CME talk, and it is sponsored in whole by Pedifix Medical Foot Care. The information and opinions herein are in no way endorsed or supported by the Icahn School of Medicine at Mount Sinai. So the subject of shoe disinfection comes up predominantly when podiatrists or dermatologists are discussing fungal infections of the feet. So as we get into the body of the talk, I'm going to review some of the basic science of fungal infections of the foot, and then we will get into the science on disinfection. So the pathogenic fungi are classified as superficial or deep. The organisms that cause tinea pedis or onychomycosis are superficial fungal organisms. There are three genera of superficial fungi, and they include the microsporon, which is rare on feet, the epidermophyton, and trichophyton. The trichophyton genera is the most common cause of tinea pedis and onychomycosis. Dermatophytes harbor on the skin by settling on the skin and emitting an enzyme called keratinase, which breaks down the structural integrity of nails, hair, and stratum corneum. Tinea pedis, when viewed globally, is a serious medical concern. It is the most common fungal infection worldwide today, and it's also noted to be spreading fairly rapidly. It affects approximately 70% of the United States population. When not treated properly, it may be a risk factor for the development of onychomycosis, bacterial cellulitis, and flares of eczema and asthma. This slide is an important slide because when we speak of the cycle of fungal recurrence and chronicity, we are talking about the facts that dermatophytes can survive off of the human body as spores. They are, in fact, ubiquitous. It is almost impossible to avoid contact with dermatophyte organisms in life. There is a genetic predisposition to chronic infection and recurrence of tinea pedis. Patients with chronic infections may and usually do shed spores throughout their home. Patients may reinfect themselves and other family members who may also be genetically predisposed. Now, when I say dermatophytes are ubiquitous, virtually any place that you can go to can be teeming, in fact, with dermatophytes. So first source is animals, other people, clothing, as you see here, footwear and socks, damp surfaces, pool, gyms, anywhere there's a tendency for moisture on the ground, in soil, for those who are active in gardening and landscaping. Certain types of community prayer involve barefoot prayer with multiple people in the same area. Gyms, wrestling mats, and exercise mats are also usually teeming with organism. And again, speaking genetics, there's a susceptibility factor that is involved. So all of these areas are places of possible contamination with the dermatophyte organisms that cause initial infection. Now, there are two types of spread. One is called extension, which means it's going to a contiguous site. And in that example, we would talk about tinea pedis going to cause onychomycosis, as well as tinea manum, because your hands are readily on your feet. So these are direct extension to contiguous sites. The second way that people can get a dermatophyte infection is by transfer of the primary focus on the foot to a second body site, causing either tinea cruris or tinea corporis. And the typical way that these are spread is with towels after bathing. So we become aware then that tinea pedis, which is generally referred to as a very benign common infection, can and does lead to more complicated issues on other sides of the body. Based on this mechanism of transfer and extension, the concept of shoe sanitization potentially has far-reaching implications in inhibiting body-wide infections. Now, there is a very strong association. Some people, including me, feel that it's virtually a 100% association between chronic dry scaly tinea pedis and onychomycosis. So, in fact, we know that without aggressive treatment of the skin, it becomes very difficult to get any success on systemic treatment of the nails. The course of disease starts out as recurrent acute infections leading to chronic infection. When the toenails become involved, cure is very difficult, as you already know. T. mentogrophites causes most vesicular acute infections, which respond readily to treatment and do not really become implicated much in chronicity. T. rubrum, however, is responsible for most chronic scaly infections and is the culprit most of the time in onychomycosis, and it is much more difficult to cure. Now, Moschella, Pillsbury, and Hurley, in their text many years ago, categorized types of tinea pedis as dry squamous inflammation, vesicular and bullous lesions, and intertriginous inflammation. So we're just going to add to that the development of onychomycosis, which again occurs mostly as a result of the dry squamous inflammatory type, but possibly, of course, can be derived from these other types of tinea if they become repetitive and chronic. So these are three photos showing the acute vesicular, chronic dry scaly, and interdigital types of tinea pedis. We know that the acute vesicular type is most commonly occurring in the long arch area, and it is recurrent in web spaces and toes. Blistering is noted clinically with accompanying severe itching, and we know from experience that the areas that itch the most are the ones with the fresh bullous appearance. However, the good thing is that this infection is very easily treated with commonly available topical antifungals. The interdigital type of tinea pedis is most common in the third and fourth toe webs, but may involve all. Yeast, bacteria, psoriasis, as well as dermatophytes may be involved. When bacteria is present, it is very difficult to isolate dermatophytes. And erythrasma, which is a interdigital corynebacteria infection, is also a concern. So when we have a situation of interdigital tinea or interdigital maceration and erosion, the diagnosis can be quite difficult. Remember that the humidity in a closed toe web is high and creates a perfect environment for thriving of multiple organisms. The chronic dry scaly type, or moccasin tinea pedis, has a high incidence in men over 20. It's very often mistaken or mistreated for dry skin. Toenail involvement, again, is eventually almost a certainty with very high association, and it is a common focus for tinea elsewhere on the body. I also want to remind the audience, like we said a few slides before, that a focus of chronic tinea on the feet can very often exacerbate allergic phenomena in people who are susceptible to breathing difficulties and respiratory allergies. In addition, it could be a common occurrence where flares of eczema in susceptible people can occur due to the presence of a focal fungal infection. The presentation would not be complete without a list of conditions that may resemble tinea pedis. And here you have things like atopic dermatitis, contact dermatitis, erythrasma, which we mentioned before, lichen planus, psoriasis, even cutaneous lymphoma has been known to mimic tinea pedis at times. So in any time of area of recalcitrance, it is very important to consider the possibility of one of these alternate diagnoses. Now, treating onychomycosis and tinea pedis should not be just confined to the nail. Dermatophytes are known to colonize and survive for a long duration in footwear worn by patients with onychomycosis and tinea pedis. Fungi may use sweat and skin cells trapped in footwear as a source of nutrients to create and maintain fungal reservoirs. Contaminated socks and shoes can and do act as a source of reinfection when worn by patients after achieving cure with antifungal therapy. So with these things proven in scientific experiments, it becomes virtually a certainty that failure to address this fungal reservoir in shoes can significantly hamper therapy or delay or even help avoid success. Laboratory diagnosis prior to initiating treatment must be emphasized because this enables the rational choice of the antifungal agent that's going to be used. So empirical treatment, based on the fact that these infections can become out of control, is frowned upon. And it is always better to treat with laboratory confirmation of diagnosis. In the case of resistant infections, which we'll discuss in more detail a little bit later, antifungal susceptibility testing is recommended. Now, you hear a lot now about emerging resistance of dermatophytes, and we will discuss this briefly at the end of the presentation. Effective management of onychomycosis includes disinfection of fungal reservoirs in shoes and socks, including post-treatment prophylaxis. Therefore, ultraviolet sanitizers have been developed to irradiate the inner soles of shoes and reduce fungal burden, as fungi absorb UV light with germicidal effects. Now, the typical in-shoe wavelength of UV sidal light that is used is 254 nanometers, and irradiation with this wavelength is one of the most common techniques and elicits a highly germicidal effect. In addition to fungi, it's effective on bacteria and virus particles. The mechanism is mainly related to the absorption of UV light by nucleic acid components, causing damage to the DNA of the organism. Extension of T. rubrum hyphae was strongly inhibited by 254 nanometer UVC irradiation. Now, this is a graphic of the effect of 254 nanometer UVC light. On the left side of the frame, we see the hyphae on culture before plate irradiation. And in the top frame, where through no irradiation, you can see the hyphae multiply rapidly and take over the entire surface of the plate. And where the radiation was used on the bottom three frames, you see that virtually no hyphae survive. And of course, the ability to infect depends on the numbers of organisms that can survive. So this illustration dramatically shows the contrast between an untreated organism and a treated one with the UV sidal light. Now, antifungal resistance comes in two forms. One is clinical resistance, and I believe that this is what we are seeing currently, where most people are saying that the dermatophytes have developed the ability to be resistant to terbinafine, for instance. I think the vast majority of those cases are what we call clinical resistance, which is a hodgepodge of variables, including incorrect diagnosis, delay in initiation of therapy, suboptimal dose of the drug, insufficient duration of treatment, poor drug penetration into the nail plate, drug-drug interactions, patient noncompliance to the treatment regimen, and relapse or reinfection. So clinical resistance is the type of resistance that's related to host or drug-related factors. In microbiological resistance or true organism-related factors, we have both innate primary resistance, which is a innate structural or functional characteristic of the fungus that contributes to resistance. And then we have the acquired secondary type, which is due to overexpression of the drug target, an altered drug target, upregulation of efflux pumps in the organism, decreased prodrug metabolism, drug sequestration in biofilms or the development of biofilm that increases resistance, and mannan expression on fungal cell wall to evade the host immune response. So in conclusion, dermatophyte infections are an expanding global problem. In certain high-risk profile individuals, such as diabetics, those with PVD, in the immunosuppressed, these infections may lead to more serious complications and other infections. Exposure is virtually impossible to eliminate. Host susceptibility is largely genetic in chronic cases. and footwear is a major reservoir of organisms. So therefore, shoe sanitization makes total sense as part of a multi-pronged approach to preventing, managing, and limiting recurrence of dermatophyte infections.